So as we continue to build on the prior discussions of today, this panel will take a focused look at the role of immunotherapy in the early age onset cancer landscape across tumor types. As a rapidly advancing field, immunotherapy continues to redefine cancer care, offering robust and durable responses, improving survival and quality of life. This session will present the current and emerging role of immune-based strategies in managing early age onset cancer. We'll examine how younger patients' unique immune biology may influence response. We'll review recent medical advancements and highlight opportunities to optimize patient selection through biomarker-driven approaches. I will be moderating this session, and I'm joined today by Eric Hamilton, who is a stage 4 MSS colorectal cancer patient and advocate. And welcome as well to our medical experts, Dr. Myri Lucas, a medical oncologist at BC Cancer Surrey, who has expertise in gynae and breast cancer, and Dr. Anu Krishnamurthy, who is a medical oncologist at Roswell Park Comprehensive Cancer Center in the US, who has expertise in GI cancers as well as cell-based therapies. So immunotherapeutics have really transformed the oncology landscape. These remarkable drugs kickstart the patient's own immune system and prompt the patient's own body to seek out and destroy cancer cells with really unparalleled efficacy. Patients often experience robust, complete, and durable responses to immunotherapy, and this benefit is realized across cancer types. I personally have supported and connected with many patients whose access and response to immunotherapy has taken them from a terminal diagnosis to no evidence of disease. But traditionally, immunotherapies have only been available and effective for a very small subset of the advanced or metastatic cancer population who actually respond to this type of therapy. So patients who have tumors that are MSI high or have deficiency in their mismatch repair function, they will often respond really well to immunotherapies. But if we look at colorectal cancer as an example, this accounts for only maybe 3 to 5% of the patient population. The balance of the colorectal population, or colorectal cancer population, has tumors that are microsatellite stable, so MSS, tumors like what Eric has. And these tumors are mismatch repair proficient. And unfortunately, this tumor characteristic had not really shown to be responsive to immunotherapies historically. Now, I use colorectal cancer as an example, but similar challenges are present across multiple tumor types. However, the immunotherapy landscape is changing, and scientists are working very hard to figure out how to get these MSS tumors to respond to immunotherapies so that more patients can benefit from this life-saving class of drugs. And that's what we're here to talk about in this panel across tumor types, and we will have a particular focus on colorectal, breast, and gynecologic cancers. So before we get into the more kind of science-based discussion, I'd really like to hear from Eric, who is a young metastatic MSS, so microsatellite stable colorectal cancer patient. So Eric, welcome, and thank you so much for being with us today and sharing your lived experiences and perspectives with us. Eric, maybe perhaps you could just start today by telling us a little bit about your cancer journey so far, maybe what types of therapies you've been able to access for the management of your disease.
Thanks, Cassandra. It's nice to talk to you again, and I'm honored to be here. I'll start my journey in 2022, which is when I was first diagnosed with colorectal cancer. And I was 41, mid-career with a wife and 2 children, Byron and Julianne, um, doing my thing. I was fit and healthy, had no history in my family of colon cancer, barely knew what it was. I was the guy at the office who went to the gym at lunch. And in the spring that year, I had some rectal bleeding and some fatigue that wasn't normal. And to make a long story short, I went to my family doctor when I learned that there would be a significant wait in the public system for a colonoscopy, I paid for a procedure called a virtual colonoscopy from a private lab. And then when I received the call from my family doctor, that there was the mass in my colon was likely cancer. And at the time, I was on a work call, and I was thinking about camping trips for that coming summer. So that just sort of emphasizes the impact it can have when you're an under 50 patient. So I was diagnosed as stage 3B with a left-sided tumor with some local lymph node involvement. And my treatment at that time was a success. I underwent a laparoscopic surgery at the Royal Alex Hospital here in Edmonton. I have no stoma from the surgery. It went very well, and I completed adjuvant chemotherapy at the Cross Cancer Institute. And my follow-up scan was clear, and I recovered and went back to work, and life was good again. And I thought I had the chance to leave the disease behind. But I was still on surveillance. And unfortunately, a surveillance scan about a year after my treatment ended showed that the disease had returned in my liver and some nearby lymph nodes. And if you talk to any cancer patient who's been through this, where you undergo successful treatment, you become cancer free, and then the cancer returns, it's even more devastating at that point than the initial diagnosis. So it was crushing because I knew I was a metastatic patient, and the game has changed. It's more complex. The numbers aren't as good, but I underwent an open surgery with curative intent to remove the lesion in my liver and some of the lymph nodes. And the recovery was difficult for myself and my young family. Um, Unfortunately, the disease persisted in my retroperitoneal lymph nodes on the next scan, and I was put on a systemic therapy called FOLFIRI with a biological agent called panitumumab. And although I can take treatment breaks, I have to remain on this treatment to keep me alive. So the good side is that the treatment continues to be effective, keeps my disease at bay such that it's not even visible on scans. And the disease has stayed out of my liver, which is important for immunotherapy, I understand. So I'm on a 3-week cycle of chemotherapy, which affords a reasonably good quality of life. And although I've spent significant amounts of time away from work on sick leave in the past 3 years, I am I am able to work full time with some accommodations, which I know it's not the case for many metastatic patients. So I know that there are probably some patients out there who would trade places with me. So um, there's some aspects of my case that make me fortunate. However, I know eventually the treatment will stop working and I will have to look for the next treatment option. So I've explored the possibility of surgery, and I've been told that there would be no clinical benefit due to the lymph node involvement. So I'm considered kind of unresectable. So the disease is kind of systemic. And the common term for my situation is chemo for life, but I prefer chemo for now because I choose to remain hopeful and optimistic about future treatment options.
Thank you so much, Eric. And you really are the picture of a young metastatic patient who's living well with colorectal cancer. And at the same time, we certainly recognize that, you're always looking to the future and you're always looking for what's next. And, we've had plenty of conversations, and I know that you and so many others have so much hope for access to immunotherapy in the future. So I guess we'll dig right into that. So one concept that we hear about when we're talking about immunotherapy is the idea of tumors being hot or cold. So Dr. Lucas, perhaps you could explain this concept to us and share how tumor immunogenicity really shapes therapeutic responsiveness and clinical decisions making.
Thanks so much, Cassandra. And just say I'm delighted to be able to be part of this session today because I do think this is such an important session. We know that across so many cancer types over the last number of years or decade, really, there's been much more of a focus on harnessing the immune system to treat cancer rather than focusing entirely on traditional cytotoxic chemotherapy. So to set the scene a bit, I'm going to talk a little bit about this idea of hot versus cold tumors. So when we're referring to hot and cold tumors, we're really talking about the immunogenicity or the immune landscape of these tumors, with hot tumors having much more of a pro-inflammatory immune environment, lots of immune cells, and cold cells usually having a really lack of immune cells and immunosuppressive immune environment. And I do sometimes put the hot, cold tumors in air quotes because there's no one test that absolutely defines what a hot or a cold tumor is. Instead, we use a number of different biomarkers to help guide us on how active we anticipate the tumor's immune microenvironment to be, because this directly influences how effective we think immunotherapy or checkpoint inhibitors to be for these patients. So the biomarker tests that we use are varied, and they're usually quite specific to the tumor site of origin or the treatment we're aiming to use. So most people do not have all of these biomarkers tested for. Most is usually just one or two. And I'm sure most of these tests you've probably heard of, and they all mean slightly different things, but all give us that indication about whether there's likelihood of a response to immunotherapy. And I like to sometimes think of these tests broadly into two different categories, those that look at sort of mutations or antigens, and those that look at immune cells. So if we think about this, if a tumor has a lot of mutations in its DNA, then it's likely to produce something called antigens. And antigens are essentially little tumor molecules that sit on the tumor cell and are displayed to the immune system so the immune system can detect it. It's like waving a flag to the immune system saying, here I am. So the more mutations a tumor has, the more antigens it produces and the more easily it's detected by the immune system. So the more robust of immune response we expect. And tests that look at tumor kind of this mutation burden or antigens would be things like tumor mutational burden, something called TMB, mismatch repair or MMR, something called microsatellite instability or MSI, in case any of these sound familiar to people. Other tests that are sometimes used look more at the immune cells within the tumor microenvironment. So tumor infiltrating lymphocytes or TILs is one of these. And then we often also look at something called PD-L1. And this is a protein that's expressed on tumor cells that can sometimes suppress immune cells. So both of these tests, if elevated, give us an indication that the immune system has already been able to recognize the tumor and approach the tumor, sort of move in to prepare to attack the tumor cells. But unfortunately, the tumor can develop a number of different mechanisms to evade or suppress the immune system. So while these immune cells are likely there within the tumor, they're deactivated. So in taking that concept with hot tumors, we suspect that the immune system already has a way to recognize these tumors and often move in towards it. And what we just need to do more is give the immune system some help to overcome the mechanisms that the tumor has developed to evade or suppress the immune system. So that's why in people who have these immune hot tumors or something like microsatellite instability high tumors, that's why immunotherapy works so well, because really all it's doing is sort of unleashing these immune cells that are already there, already able to recognize the tumor. With immune cold tumors, it presents much more of a challenge in terms of harnessing the immune system, because often there's minimal immune cells around the tumor, so just unleashing them as such isn't going to do what we need it to do. So, or often sometimes the tumor has found a way to sort of stop the immune cells for actually getting into the center of the tumor. So again, unleashing them isn't doing all that it needs to do. So what we often do there, or what has been done in clinical practice sometimes for these colder tumors, is the idea of often combination strategies. So I'll use an example from endometrial cancer, which is a type of cancer that I deal with, and they use a combination of pembrolizumab, so an immune checkpoint inhibitor, and combine it with something called lenvatinib. So that's a VEGF inhibitor or a multi-kinase inhibitor. Studies so far have shown that for endometrial cancer, people who have MMR proficient or cold tumours, immunotherapy by itself doesn't seem to have the responses that we want. But we can see with the combination strategy, things work better. Lenvatinib works and targets the growth of blood vessels, and so seems to be able to change the ability for immune cells to actually enter the tumour. So by using the combination, it seems to be a better approach. Another combination of this idea of trying to transform, I guess, cold tumours into hot tumours so that the immune system can be harnessed against the tumours is a combination of a PARP inhibitor. So PARP inhibitors work by essentially changing the way the tumour cells are able to repair DNA. And that leads to mutations. Again, leading to mutations means more antigen production, means that it's more easily recognised by the immune system. And that combination with immunotherapy has also been shown to be quite effective in some cancers as well. So really, in summary, those terms hot and cold really reflect the immunogenicity of the tumours and who is more likely to respond to immune checkpoint inhibitors. And we do have to work a little bit harder with cold or less immunogenic tumours to try and find different combinations with immunotherapy to be more effective.
Thank you so much. That was a really great explanation of a very complex topic in a 6-minute time period. So thank you for that. So the symposium is dedicated, of course, to early age onset cancer patients. And in my own experience, these younger patients are very keen to learn about and avail themselves of immunotherapies. But Dr. Krishnamurthy, I'm wondering if you could tell us, how does age-related immune biology impact response or resistance to treatment?
So first of all, I would like to thank CRAN for inviting me to the symposium. I am honored to be talking to all of you today. So I will answer that question by starting off with our older population, and I will talk about a concept called immunosenescence, which has been studied over time as a potential reason for cancer development, and also maybe having an impact on how people respond to immune checkpoint inhibition and other immunotherapies. Essentially, what immunosenescence is an aging immune system, and what we typically see there is a decline in adaptive immunity. There is increased T cell exhaustion, meaning those T cells are really quite tired, and there is a shift towards an immunosuppressive cell population there. The regulatory T cells are out there kind of suppressing all those active cytotoxic T cells. All of these things end up fostering this environment where tumors can grow. Efficacy of immunotherapies such as immune checkpoint inhibitors and CAR T cells have been shown in some studies to be reduced in this kind of scenario, but the data is still limited. But what we do know is that this whole immunosenescence, this aging of the immune system, is not really the pathway for poor immune response in the early onset colon cancer population. The immune biology of early onset colon cancer patients is being studied by multiple research groups, but it is a very recent topic that's being looked into. We don't have decades of data yet, but there are a lot of groups who are interested because it's a great question, and that will help us modify treatment options that are available. So collaborative work that was done in about 2023 at the University of Michigan, they looked at the tumor microenvironment in early versus late onset metastatic colorectal cancer. They looked at the immune infiltration, the cellular engagement in tumors from about 111 patients. The early onset population showed a higher proportion of PD-L1 expressing antigen presenting cells, and I think Myri there talked about PD-1 and PD-L1 there, and increased engagement between tumor cells and those cytotoxic T cells. And they also saw increased engagement with tumor cells and those antigen presenting cells. All of this suggested that there is a more active immune environment there, microenvironment there within the tumor in the younger patient population. And hence, this kind of suggested that there is a role for immune-based therapies and responses thereby in early onset colon cancer patients. There's also recent work actually done at Roswell Park, and it was done by Dr. Vadera here, who presented it at ASCO 2025, so this year. They looked at the Cancer Genome Atlas CRC data set, and the expression of common immunotherapy targets in early onset colorectal cancer was compared to average onset colorectal cancer. And they defined early onset colorectal cancer patients as being younger than 50 years of age at the time of diagnosis. What they found was that BTLA expression was increased in this early onset population, while CD47 expression was less in this early onset population. What does this all mean? The BTLA expression can inhibit the function of CD8 T cells. So these are those cytotoxic T cells that go and kill your cancer cells. And so with the BTLA expression inhibiting these cytotoxic T cells, this can result in decreased immune function. Decreased CD47 expression may lead to decreased immune cell infiltration into that tumor microenvironment. So they're really not getting in there. So if they're not getting in there, they're not able to kill those cancer cells. So what does all of this mean in essence? So essentially, these early onset colorectal cancer patients do have an altered immune microenvironment. Something there did result in the development of that cancer, and there is an altered environment there. But it is not the same as your average onset colorectal cancer patient. So what we really need is more studies to find more answers. And that's sort of the take-home message there. I think this topic cannot appropriately be covered without touching on the tumor microbiome and the immune biology. That is another topic that there have been a lot more studies on recently. So there have been many recent studies that have shown that the early onset colorectal cancer population is associated with this unique intratumoral, so within the tumor, and the gut microbiome compared to the late onset colorectal cancer population. There are differences in the composition of those microbes and in the microbial diversity. Studies have shown that early onset cancers have increased abundance of bacteria such as Fusobacterium, Akkermansia, a bunch of them, and even oral pathogens, things that you typically found in your oral cavity, is being found within these tumors. So these microbial differences influence tumor biology, immune response, and response to treatment, such as chemotherapy and immunotherapy. So I think this area is going to be very important in the future when we are studying about treatment options. The problem with all of these studies right now is that there's a lot of methodologic variation, meaning that every group is doing it slightly differently. What we need is more standardized studies so that we have more answers that can eventually be used to determine possible treatments.
Thank you for that. That's fascinating. And it's, you know, there's very significant distinctions between early age onset cancers and the average age onset cancers. And when we think about, you know, big clinical trials for drugs, and you think about the fact that early age onset cancer patients account for, you know, usually 10% or less of the population, we're really missing out on the data for this subpopulation when we're looking at the clinical trials and the efficacy of new drugs coming down the pipeline. So a really, really important topic, and thank you for distilling that for us. So next, I think we'll move into some tumor type kind of specific information, chatting about some particularly promising trials where we've seen some great movement in activating the immune response in otherwise cold tumors. So I'd like to start with gynecological cancers. So CRAN actually completed multiple patient input submissions to CDA in this space within the past year. And I will tell you, the patient experiences that were shared with us through the interview processes were so incredibly compelling. So Dr. Lucas, at a very high level, what immunotherapy advancements are happening in the gynae cancer space right now?
Yeah, so I treat breast and gynae cancers, so I see a lot of this, and I hear the same stories from patients as well about access to different drugs and experience with these drugs. So I'm mainly going to focus my talk on endometrial cancer today, and I think the key thing here is that in patients with advanced endometrial cancer, molecular testing for MMR status is absolutely vital. We have got a number of studies now that have shown the benefit of immune checkpoint inhibitors in patients with MMR deficient endometrial cancer. So we had three main studies. The RUBIES trial looked at an immune checkpoint inhibitor dostarlimab in combination with chemotherapy. for 6 cycles followed by immunotherapy. And then this was the same chemotherapy versus placebo. And in this study, there were significantly improved outcomes in terms of progression-free survival and overall survival in those MMR-deficient patients who received immunotherapy. We then had the Keynote 868 trial, which essentially did a very similar thing, but with pembrolizumab as their immunotherapy agent, and a few differences in trial design that we won't go into today. But key thing is that, again, it showed improvement in overall and progression-free survival in patients with mismatched repair deficient endometrial cancer. And then we had a third study. It was called the DUO-E study, and this one was slightly different. It had 3 treatment arms. So again, the chemotherapy plus placebo, chemotherapy plus immunotherapy, but this time with another immune checkpoint inhibitor, durvalumab, and then finally chemotherapy plus immunotherapy. And then in the maintenance setting, this was followed by immunotherapy plus a PARP inhibitor called olaparib. And again, there was a significant benefit shown in those patients with MMR deficient tumors with the combination of chemotherapy and immunotherapy. Interestingly, there was no real difference in outcomes for those who had MMR deficient tumors with the addition of olaparib. So really what we're saying there is that these patients, because they're that immune hot type of tumor, they don't need the olaparib in addition to the immunotherapy. They get such robust responses from the immunotherapy alone. So these 3 studies really clearly showed the benefit of immune checkpoint inhibitors to chemotherapy in MMR deficient patients. Doesn't really matter which immunotherapy agent, all of them showed a benefit. But I think the biggest question we all have is, what about those with the MMR proficient endometrial cancers? Because this does make up the majority of our endometrial cancer patients. And when we tease out the results from these 3 studies, we do see that there was a bit of a benefit with the immunotherapy in these MMR proficient groups, though unfortunately it was far less pronounced than the MMR deficient cohort, and mainly more in progression-free survival rather than overall survival, but still an improvement. Some of the subgroup analysis in the different trials are a little bit hard to interpret because they're not fully statistically significant, but we definitely see a signal there that immunotherapy has some benefit in the MMR proficient group. There's likely, I guess, like my takeaway from that is that there's probably a group within that MMR proficient group who we can't define further at the moment, who get that benefit from the immunotherapy. There is some data to suggest that those patients with other molecular features, such as P53 mutations, might be the ones within that MMR proficient cohort who derive the most benefit from immunotherapy here. And currently, I'm not sure about worldwide, but in BC anyway, we do have an access program for immunotherapy for MMR proficient patients with endometrial cancer. So we can get these patients immunotherapy, which is fantastic. Another big question, I guess, this raised is, what about that PARP inhibitor combination? Because I talked about before, we love the idea of combining 2 treatments together to hopefully, in this case, make more mutations, make more antigens, make this cancer more visible to the immune system that we then can upregulate with the immune checkpoint inhibitors. And it's a bit tricky when we look at the DUO-E study in that group who wasn't mismatch repair deficient. On paper, it definitely looked like that combination worked better than the combination of chemotherapy plus immunotherapy, but the trial wasn't actually powered to give us that answer. So the trial only powered it to compare it to the chemotherapy alone arm. So it's really difficult to establish how much benefit that PARP inhibitor had here. I suspect it does have some benefit, but again, trying to tease out who gets that benefit, it's unclear. And unfortunately, the way that trial designed didn't give us that answer. So unfortunately, at the moment, I don't believe this, to my knowledge, combination is available in Canada. And I do think that's something we see across the board with issues with funding and access to cancer treatment. And I think this is a really interesting combination, and hopefully there'll be more studies looking in that in the near future. I also treat breast cancer, and I was briefly going to pivot to a few things with there, but unfortunately, the use of immunotherapy in breast cancer has been relatively disappointing. It's quite dependent on the type of breast cancer. And to date, in our largest cohort of breast cancer patients who are hormone positive and HER2 negative, studies looking at immune checkpoint inhibitors have been relatively disappointing, despite the fact that we know that the number of tumor infiltrating lymphocytes in breast cancer does indicate how well they're going to respond to chemotherapy doesn't seem to correlate with immunotherapy for some reason within this breast cancer cohort. What is exciting, I guess, in the field of breast cancer is something called an antibody drug conjugate. So not so much immunotherapy, but the idea of using an antibody, which is targeted to something expressed on the cancer cell, linked to a bit of chemotherapy. So more of a targeted way of delivering chemotherapy to our patients, and it seems to be very effective in the breast cancer space.
Okay, thank you. Some very exciting advancements. Certainly, still more research and more work to be done to fully realize the benefit and the potential of immunotherapies. But it's so wonderful to hear that we're making advancements. So thank you for that, Dr. Lucas. Now let's talk about colorectal cancer. So we are hearing so much excitement about the ongoing research in immunotherapies for MSS, metastatic colorectal cancer. It's an advancement that is desperately needed, as 95% of metastatic colorectal cancer patients are not eligible for immunotherapies currently. And, colorectal cancer is the second leading cause of cancer death in Canada. So turning back to Dr. Krishnamurthy, can you please tell us about the advancements in immune response activation in colorectal cancer?
I am so happy to be covering this topic today. It is much needed. So essentially, let's get into it. So like you said, mismatch repair deficient colon cancers are where we see a lot of response with checkpoint inhibition, but it's a very small group. So what about the rest of colon cancer patients, especially our early onset colon cancer patients? Most of the time, almost always, mismatch repair proficient metastatic colon cancer patients are told immunotherapy will not work for them. But of late, we have a combination of checkpoint inhibitors, botensilimab and balstilimab, that have shown promising results in the MSS population. Botensilimab is a next generation CTLA-4 inhibitor, which has an enhanced Fc region. The Fc region is the tail of the antibody that interacts with cell surface receptors. So the enhanced Fc region allows it to bind more potently to all these antigen-presenting cells, and result is that there's greater immune activation. Balstilimab is a PD-1 inhibitor, like your nivolumab or pembrolizumab out there. The combination has been studied in several clinical trials for colorectal cancer, and particularly in that MMR proficient space. It all started with a phase 1 clinical trial where they had this group of heavily pretreated patients with MSS CRC that were treated with the BOT-BAL combination. It was well tolerated. Side effects were fatigue, diarrhea, fevers, and the objective response rate was 17%. So they went on and did, they continued with the study. The phase 1b follow-up data from that same trial presented at ASCO 2023 looked at 59 heavily pretreated patients. And there they had, again, good objective response rates. And the 12-month overall survival rate was 61%. So everyone was starting to get very excited by this point. Updated efficacy data was then presented in ASCO 2024. And there the investigators described an ORR or objective response rate of 22% in these patients. And these were patients with non-liver metastases. I think you alluded to this, Eric, when you were talking. Responses were noted in challenging sites such as the peritoneum, soft tissue, pleura, and the brain. So this data was then further updated at ESMO GI 2025, so this year. And the data for the cohort of patients with treatment refractory, microsatellite stable, metastatic colorectal cancer patients without active liver metastases were presented. And just to get into the weeds a little bit, there were 123 patients who received this combination. And the updated objective response rate was 20%. And there were 3 complete responses and 21 partial responses, which is really good given the dismal data from all the previous immunotherapy that we have tried in colorectal cancer before. Duration of response was 16.6 months, which shows some good sustained benefit in these responders. And most importantly, median overall survival was 21 months. Remember, keep in mind, these are heavily pretreated patients. On an average, these patients had all received 3 lines of therapy already. So this was great median overall survival And 20% of patients were alive and off treatment at follow-up of 18 months. So that kind of speaks to what their quality of life is like. So very exciting data there. There was another global phase 2 trial that was also presented at ASCO 2025, which had a larger group of patients. I think this had more to do with asking the question, do we really need the combination of botensilimab and balstilimab, or can we really achieve all of this with just that botensilimab alone? Do we really need that PD-1 inhibitor? And there they did show that, you know, the combination did far better than the monotherapy. So we really needed the two together. But then the data, the overall survival and progression-free data is still pending from that trial. And just as a comparison, if you look at standard therapies like Avastin, which is used in the third-line setting, the objective response rates on those trials were 6% and 1.2% with Lonsurf alone. So this kind of gives you a sense of what the difference is in terms of response. But then if you look at the overall survival in those trials, median overall survival was 11 months. So clearly that overall survival and PFS data for BOT/BAL will be very relevant. Most importantly, I think we need a phase 3 trial for this combination. And the Batman trial is being sponsored by the Canadian Cancer Trials Group. The study is looking at botensilimab and balstilimab versus best supportive care in chemo-refractory, unresectable colorectal adenocarcinoma. And their primary endpoint is overall survival. The question they are asking is, are patients with unresectable colon cancer who have had other lines of therapy going to live longer with this BOT/BAL combination? And is it going to help improve their quality of life? Both very relevant outcomes that we need to look at. The eligibility criteria for this trial is broad. This will allow us to look at efficacy across the entire spectrum of metastatic colorectal cancer, and the accrual to this trial will be swift. So we are going to get some data very quickly. It's a global trial, and the results from this trial will be practice-changing, especially if there is positive efficacy data. I feel very optimistic about this trial, and I'm really looking forward to the results. One thing that I also want to mention, another trial that we will just touch on, is the NEST-1 trial. It is a small trial where they just had 12 patients, and they looked at the neoadjuvant use of BOT/BAL. So in the resectable patients with either mismatch repair proficient or deficient colorectal cancer. They did see some good responses in tumor downstaging, so they expanded this trial and have added more cohorts. So that data will be interesting as well and something to look forward to. I didn't get into very much of the other immunotherapy agents because there was so much to talk to about this combination. But in conclusion, I think there's much to be excited about in the colorectal cancer space. We focused on the immune biology, particularly checkpoint inhibition, because this has the most mature data. But there are other therapies out there that are showing promise as well. So I'm hoping to see this whole landscape be transformed in the next decade, or at least before I retire.
Thank you. And we're going to come back to the BOT/BAL and talk about that a little bit more with Eric. But before we do that, Dr. Krishnamurthy, do you want to touch a little bit on some of the cell therapy work that you're doing?
Yes, I can talk about the cell therapy. So Roswell's been very interested in looking at solid tumor cell therapies, and we are essentially looking to develop CAR T cells, modified CAR T cells that not only just go and attach themselves to their target antigen, but then also are able to regulate the tumor microenvironment so that we can make those CAR T cells more effective. Currently, we have this GPC3 targeted CAR T cell for HCC, but we are looking to have more CAR T cell options available for pancreatic cancer as well as colon cancer. And so those are in the works. There are some trials out from China that are specifically looking at colorectal cancer and specific targets like EpCAM for colorectal cancer in terms of CAR T cells. They are all small studies because that's the way these CAR T cell trials go, and they show some promise. But I think more expanded trials, particularly with our population, will be helpful in addressing that that space as well.
Thank you for that. So I will remind our audience as we're getting close to our Q&A period to please engage with us and provide your comments and questions in the chat below the video stream. But before we get into the audience questions, There's so much excitement, and I know amongst the colorectal cancer population, we talk about BOT-BAL at our support group meetings, our monthly support group meetings, and on our one-on-one calls, and I'm hearing, a lot of positivity about that, and science is it's moving so fast, and the treatment landscape is evolving at an unprecedented pace. And immunotherapies represent a really important part of that landscape. And for patients, the thing that I hear over and over is that they often represent hope. So after that really enlightening discussion, I'd like to turn it back to Eric to share his own, reflections and thoughts on what we've just chatted about.
Thanks, Cassandra. Well, you mentioned hope, and hope is so important as a patient, because many of us have dependent children. We're still in our careers. We should have decades of good life left, and all of a sudden we find ourselves battling this disease that can often be terminal. So hope is what gets me out of bed in the morning and allows me to continue. But I just want to say something about the current options. I mean, chemotherapy is a blunt instrument. I don't want to sound ungrateful, because it's keeping me alive, but it comes with significant side effects that impact quality of life, and it's not curative for colorectal cancer. So early age onset patients tend to be risk tolerant. We will take a chance on a treatment such as a surgery or an experimental immunotherapy combination if there's that upside, if there's reason to believe that this could get me to a place that's better than where I'm at right now. And I'm comfortable speaking for most early age onset patients when I say that we're willing to take risks. The clinical trials for colorectal cancer in Canada tend to be for patients who have exhausted their treatment options on the standard of care. So it's like a last resort. So their disease tends to be quite advanced. And I've noticed this through my research, and my oncologist has confirmed this is the case. And just to be clear, I don't want to take anything away from patients like that. Obviously, they need help. I'm not quite there yet, so I'm a little bit more fortunate than that. But the data on the breakthrough immunotherapy combinations like BOT-BAL suggest that they're more effective at an earlier stage, or if the disease is under control. And so you have this situation where the people who are able to access these treatments on clinical trials are it's less likely to be effective for them. And I would take BOT-BAL tomorrow if I could. I know this clinical trial is not set up that way. It's not possible. I wouldn't meet the criteria, but the fact remains that the clinical trial system doesn't necessarily allow for patients to accept some calculated, informed risk when it comes to taking treatment decisions on their own behalf, especially if we have treatment options remaining. So I would just be looking for a clinical trial with some data to suggest that it could have a high upside, and that could be more desirable than my current treatment path, because we just want our lives back.
Thank you for that insight, Eric, and it's a really important perspective, and I'm so glad that you shared it. And it segues actually very nicely into our Q&A, because we're having plenty of questions coming through about BOT-BAL. So starting with, I suppose, how would patients who suspect they may be eligible seek a referral for the clinical trial within Canada? I don't know, Dr. Krishnamurthy, if you're comfortable speaking to that within the Canadian context. I can certainly jump in if you need to as well.
So I did notice that on the website, there is a contact point that is available, and there is a fact sheet that is available to patients. I think the trial is meant to be available across multiple centers by the fourth quarter. That's what I understand, but I do want you to weigh in as well.
Yeah, certainly. I mean, we're still waiting on official announcements, but I know it is anticipated to be beginning recruitment, I think later even this month. and CRAN each and every month puts out monthly clinical research and treatment updates. So we're keeping a very close eye on it, and we'll be communicating that through our monthly updates, and certainly with one-on-one calls. So stay connected, and we're happy to provide the trial sites and the referral information as it becomes available. We have another question about when, and this is a little bit difficult to answer, but provided provided it reads out as well as I think we're anticipating and hoping that it will, when do we think BOT/BAL might be available in more kind of in a publicly funded sense? How long is it going to take to get the data to start moving this drug therapy through the drug funding process?
Yes, you're right that it is going to be a little difficult to predict, but I would suspect we would at least have preliminary data in 2 to 3 years. Is that the early preliminary data would come out, and then we would have the final data come out in 3 to 4 years, is what I expect.
Thank you. Dr. Lucas, when you were speaking earlier, you alluded to tumor mutational burden. And in Canada, we're increasingly hearing about high TMB. And could you tell us a little bit more about how it may play a role in response to immunotherapeutics for patients with MSS tumors, and what's the evolving evidence looking like in that space?
Yeah, absolutely. So, like we spoke about before, the tumor mutational burden essentially looks at how many mutations is in the genome of the cancer, and that hopefully predicts how much neoantigens is likely to produce. It's difficult to say because they're all different tests. So, it's not necessary that if you were, say, MSS, that you may not have a high tumor mutational burden. So there can be different tests that mean different things and sometimes change the way they might respond to immunotherapy. The tricky thing is that the studies that have been done in specific cancer types usually use one biomarker as their predictor for response. So oftentimes if we have other results of other different biomarkers that may predict more immunogenicity within the tumor, it's hard to infer how that means exactly how they'll respond to the treatment because it wasn't always delineated within the clinical trial.
Okay, thank you. And then in follow up to that, we're just coming off of a session talking about comprehensive genomic profiling, and you listed, a number of biomarkers that are associated with potential immune response. So I wonder perhaps what's your kind of perspective on the need for comprehensive genomic profiling for metastatic cancer patients to inform these clinical decisions?
Yeah, absolutely. And I think it is quite cancer dependent sometimes. I think there's some tumors that we can do a lot of testing for already that give us indications, or lots of other really effective treatments or other known mutations that have targeted medication. That is probably what we want to focus on rather than always sometimes in immunotherapy. I think comprehensive genomic testing is really interesting. I think if people have access to it, it is great to have more information. There's a couple, I think, of tricky things in there. One is that sometimes that immune landscape can change over time. So sometimes if people have certain testing done, it doesn't necessarily mean it will be the same at the time of their tumor progression. So I think that's one important thing to know about it. At the moment, it's quite costly, and particularly if people are having it multiple times within their cancer journey. I always like to have as much information as possible, but oftentimes we can't always act on that information, which again, the access and funding issue comes into it.
Thank you. And a question for Eric coming from the clinician perspective. So as a clinician, it can be difficult to know how much information or perhaps how much hope to share with patients when you're talking about clinical trials, when you're talking about evolving evidence. How can clinicians balance hope with evidence?
Oh, that's a great question. I don't think I've ever been asked that by a clinician, but I will just say my doctor at the Cross Cancer Institute has been great. He doesn't give false hope, but he's never given timelines. I hate hearing about doctors giving timelines to patients because there's so many reasons not to do that. But when he talks to me about clinical trials like BOT-BAL, I mean, he sounds as excited as I do about that. And he uh, he had a gut instinct that BOT-BAL could change the way the disease is managed in a very substantial way. So for a person who's very evidence driven, that it sounded really good to hear that he had a gut instinct. So I think I like the term grounded hope. Like if it's grounded in evidence, that's really meaningful.
Thank you, Eric. And then back to that BOT-BAL, we've got lots of interest on that in the chat. Just a question about what phase is the trial when it rolls out in Canada?
That's a phase 3 trial.
Thank you. Okay. All right. So I think that wraps up our questions for this session. So again, thank you so much to our two clinical expert panelists. It's such an exciting topic, and it's such a complex topic in which you both were able to really clearly communicate. So we really appreciate that. And Eric, thank you as always for putting yourself out there, being vulnerable, sharing your insights and your perspectives based on your lived experience. You are, a remarkable advocate, and you do so much for the colorectal cancer community and the young adult cancer community. So thank you so much for your contribution today. And then with that, I suppose we will wrap up day one of the 2025 Early Age Onset Cancer Symposium. A big thank you goes out to all of our expert speakers, as well as the viewers who have stayed with us, particularly throughout the day. We absolutely look forward to hosting you again tomorrow, and I will be turning it over to Philomena for some closing remarks.